أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي. My dear friends and my colleagues and my students who are following me for the sessions of on nephrology. Previously I have done the renal function tests and what are the investigations needed to decide it. I am Professor Sayyid Rihada. I am visiting professor of the medicine, Kinachen Medical University. These are the lectures actually meant for the final year or third year. But those who are appearing in the FCPS examination, or fellowship examination, can be benefited if they listen carefully. Now, today I want to discuss something about the low urine output. Low urine output for the final year MBBS students. Clinically, the renal functions can be judged by the urine output. Excessive amount polyuria or small amount oliguria. These are the terminologies we use. Hypouria and hyperuria is not the terminologies, correct terminologies. So clinically the patient may present with this, because daily urinary output should be exactly, it is not exactly, but it is what you have actually, what is called is the intake of the fluid. It should be actually at least 40% should be excreted out. At least 40% to maintain the milieu interior of the body, that is internal environment. Otherwise there will be a problem. This is clinically how we can judge. As an investigation is concerned, you do the urine RE examination, you do the urine, the blood urea, serum creatinine and electrolytes, which are indirect evidence of the renal functions. You can more precisely you can do the 24-hour urinary creatinine clearance or 24-hour protein clearance or 24 hours protein output. These are the things which are biochemical markers for the renal functions are concerned. Helping tools are the radiologies can be helpful. Ultrasonography and plain radiology or contrast radiology, etc. In the world, according to the American College of Nephrology, there is no single test which is 100% sure about what is called is the GFR, the glomerular filtration rate. That is the exact, that will clear the exact position of the renal function. But its calculation is very difficult. Nowadays they are doing in the lab with eGFR, electronic formula, or with the help of this, they calculate the eGFR. On the basis of the eGFR, they have divided the kidney diseases, chronic kidney diseases. So the substances which are clearly excreted out, urea, creatinine, and there are other substances as well, they are not 100% cleared out from the urine. So these are not the 100% predictors of the renal function. Before starting this, you have to clear yourself. Remember that the serum creatinine will overdiagnose the renal function, and blood urea will underdiagnose the renal function. So they are not 100% perfect markers. Indirectly, yes, they are good. For the follow-up is concerned, yes, but you have to add the other markers as well. That is serum electrolytes, for example. And you can do the arterial blood gases to be more sure about it, about the functions of the kidneys are concerned. A scenario now, let's start with clinical. 24-year-old truck driver was experienced pain in the low back while he was changing tire. Now, general practitioner injected some analgesic and advised some painkiller, and patient took double dosages to come down the severity of the pain, because he has to drive this truck from Karachi to Peshawar. So he had taken that analgesic, rather once or twice a day he had taken 2 tablets, double the dose, for 4 hourly or 6 hourly, unless the pain was relieved and he was able to drive. After 5 days of this incident, he had taken the analgesics for 3 days. He noticed that the puffiness of the face followed by the increased somnolence and decreased urinary output. Temperature was 99 degrees Fahrenheit, pulse was 111 per minute, tachycardia irregular, indicating that it's possibly in atrial fibrillation. The blood pressure is very high, it is about 187 by 99. It is stage 3 hypertension. You can say that it is hypertensive urgency. Now, dehydration is positive, the pedal edema was positive, the Glasgow Coma scale was 11 by 15, so somnolence, increased drowsiness. Hemoglobin is 11.6 gram, although it is lower down, but it is not much of a mild anemia. THC 4000, platelet is 430,000. Blood urea is 170 milliequivalent or milligram. Now, serum creatinine is 5.9, sodium is 125, potassium is 6.54, chloride is 99, bicarbonate is 9. 9 means that the normal is 22 to 28. It means the patient is in the metabolic acidosis, hyperkalemic acidosis. Hyperkalemia is mostly associated with the acidosis. Hyperkalemia. And hypokalemia is usually associated with the alkalosis. Usually. So, this is hyponatremia along with the hyperkalemia along with the metabolic acidosis. Now, question arising from this scenario is that in this, the differential diagnosis, other necessary investigations, the most likely diagnosis, and the lines of the therapy you want to do, what you are planning to do it. Now, drag the soft data of this patient, drag the hard data of this patient. I have already told you about it, the scenario, and let the differential diagnosis, and list it, and the most probable diagnosis now. Now, coming that the patient is diagnosed provisionally in the acute renal failure. Acute renal failure is the condition in which the renal function deteriorates in hours to days, while the chronic renal failure is the condition which the renal functions or renal decompensation occur in months to years. And this is how we actually clinically define it, rather. The acute renal failure is a chronic renal failure. And between the two, it may be possibility of the subacute type of it, of the renal failure between it. The patient has got a renal failure and there is an acute exacerbation in the chronic renal failure with the acute renal failure. There is possibility like this also, depending upon the clinical scenario. So directly discussion is going on. The abrupt decrease in the renal function resulting in the accumulation of the nitrogenous compounds such as blood urea, which is the end product of protein, and creatinine. This occurs in hours and days. The terminology which we are using is a pathological terminology is called azotemia. Terminology we are using biochemically is azotemia, is a medical condition characterized by the abnormally high levels of the nitrogen containing compounds such as the urea, creatinine, various body waste compounds, and other nitrogen rich products or compounds in the blood. It is a retention. It is largely related to the insufficient or dysfunction filtering of the blood by the kidneys. It is usually related. Either the blood is not going 100 ml per cycle, cardiac cycle. In one cardiac cycle, the renal input should be 1200 ml. You can say it is about 1/5 of the cardiac output is received by the kidneys in each cardiac cycle. It may be possibly that the kidneys are not properly nourished, or there is obstruction to this nourishment in direct way or indirect way. Secondly, the possibility that there is malfunctioning of the nephron. The nephron is not functioning properly because of the disease process has stopped the normal function of the kidneys. That is called the renal type of azotemia. So there is pre-renal azotemia, there may be a renal azotemia. It is possibly that the input to the kidneys is normal, the renal function done by the nephron is normal, but the output is, of course, the collecting system and other things which are going down as a byproduct urine. It is not filtering. It is not the passage of the urine which is seen normally. There is some obstructed nature of the problem going on in the tubular system, collecting system, and that is called the post-renal azotemia. So there is pre-renal azotemia, the renal azotemia, and the post-renal azotemia. If you convert it into the clinical terminology, you say the pre-renal acute renal failure, or it may be the renal, or it may be post-renal acute renal failure. Now, this is the potential causes of the increased blood nitrogen or creatinine without acute renal failure. Possibility is there because there are false markers. I already said that. Increased blood nitrogen may be produced by increased protein intake, infusion of amino acids, GI bleeding, catabolic states, steroids has been given, and large dosage tetracycline has been given. It will increase the blood nitrogen, but without their acute renal failure. And there are chances of the false marker, again, increased serum creatinine. I say that the overdiagnosis. The increased release from the muscles, or because of destruction of anything, decreased secretion by the proximal tubules, like cimetidine and trimethoprim actually will decrease the secretion of by the proximal tubules. And interference with the Jeff reaction. Jeff reaction is the biochemical reaction which will go in the lab. The ketone bodies will interfere with acetate and the cephalosporins will, and methanol and isopropyl alcohol, for example. So that's why there is a false evidence of the increase of the creatinine. Overdiagnosed creatinine, underdiagnosed blood urea or blood urea nitrogen. The acute versus the chronic renal failure is the history. You take the history, of course. For example, in this patient is the acute onset, known chronic, recent toxic exposure, recent hypoxic insult, recent trauma, burns, known diseases associated with the acute renal failure, for example. Known diseases, renal artery stenosis or hypertension, congestive cardiac failure, for example. Now, previously, the abdominal lab results suggesting the chronic. The patient has already dysfunctional kidney since many years. Now there is exaggeration of this. This is the acute on chronic renal failure or subacute renal failure now, in the presence of the chronic renal failure. Now, acute versus the chronic renal failure, the rapidly rising creatinine. Acute kidney size is small in chronic renal ultrasound increase alkalinity. Chronic urinary flow rate, oliguric or anuric usually in acute renal failure. Now this is what is written here. Remember that 1 milligram of the creatinine is equivalent to 40 milligram of the blood urea. The ratio is 1:40. If this ratio is disturbed, for example, 2:40, it means that it is a renal type of the acute renal failure. If it is under 0.5, for example, to 40, it is pre-renal failure. The ratio 1:40, which roughly can also tell you about that it is pre-renal failure or the renal failure acute. The terminology should clinically the patient will take the intake output charting. His intake for example 2000 ml or 2500 ml. If it what is called is anuria, anuria means no urine output or less than 50 ml in 24 hours. Normally it should be more than 500 in 24 hours, more than. I said 1/5 of the intake should be there. It should be 1/5 of the intake. The terminology we use, urea, in certain books it is less than 400 ml. In another book I have seen 300 ml. But according to the American College of Nephrologists, the urea means if you calculate properly, if it is less than 400 ml in 24 hours. Collection will tell you that oliguric or anuric or it is normal, non-oliguric. Etiology of the acute renal failure is pre-renal. A lot of causes, I already said that nourishment of the kidney is on the stake, and renal 35 to 40% of the cases, and the renal parenchyma is disturbed and destroyed, inflamed, or not functioning properly. The renal post-renal, the collecting system is not functioning properly. They are hindering the urinary output. The cases are less than 5%, and they are mostly surgical type of the cases. So there will be pre-renal, post-renal, and the renal type of the ARF, acute renal failure. Let's see some of the causes now. The pre-renal acute renal failure is the most common cause in 60% of cases. Result from the decreased renal perfusion. I already said the treatment of the cause restores the renal function, tubular function intact. Restore the function if you remove the cause. The prolonged pre-renal failure will lead to the acute tubular necrosis because of ischemia. That is called renal ischemia, renal infarction. Now, causes of the pre-renal azotemia, the biochemical terminology or pre-renal failure, intravascular volume depletion. You see in cases of the depletion, nowadays in cases of dengue fever, for example, acute intravascular volume depletion will cause the patient to go into the shock. Anything which is leading to the shock state because of the severely volume depletion, intravascular, will cause the pre-renal azotemia failure. Decreased cardiac output because of the stroke volume is very low, how the kidney is nourished. So in cases of the left ventricular failure and congestive cardiac failure, there are chances of the pre-renal azotemia. Systemic vasodilation to peripheral resistance are low. Antihypertensive sepsis will cause the systemic vasodilation, so the undernourishment of the kidneys. Or this may possibly of the renal vasoconstriction because of the disease process or because of the drugs we have used. Or drugs impairing the autoregulations like ACE inhibitors autoregulation of the system of the kidneys, like the angiotensin converting enzyme inhibitors or use of the NSAIDs. Previously, the scenario was given and he has taken NSAID in a very large dose. So he developed actually what is called as the analgesic nephropathy. It's a part of the acute renal necrosis. Renal aneurysm. It means there is renal aneurysm and 1:40 ratio, which I have said between the creatinine and the urea disturbed. You see that the 5.6 was the creatinine and 150 is the urea. If you cut it down, it will be more than the ratio, 1:40. It means it's renal aneurysm or post-renal aneurysm, but it's not acute renal, pre-renal acute renal failure. This is the mechanism of the pre-renal failure that is decreased actually or decreased due to or effective circulatory volume will lead to the activation of the central baroreceptors, which will lead to the angiotensin II production and non-epinephrine and ADH. These are acute phase reactions. And they will act on the vasoconstriction. They act as vasoconstrictors, so the blood supply to the kidney will be reduced, and there will be mesangial cell contraction in the kidneys also. A direct effect of these. And it will reduce the GFR. GFR means urea occur in these conditions. And in the pre-renal failure, there is shedding of the terms of protein from the ascending loop of Henle, and it will cause the cast which is called the hyaline casts. It is the derivative of the harms of whole proteins. In the urine, if you see the microscopy, I have told you that microscopy is very important examination, which usually missed by the lab technicians. The second type is first you take the post-renal acute renal failure. Because it is less than 5%, you know that account for about 2 to 15% of all acute renal failure. Actually, there is obstruction to the urinary flow. And the cause will be definitely, there may be renal stones, it may be possibility of the renal infarction, and it may be possibility of the bladder, it is possibility of the vesico-ureteral reflux, there is a possibility of the urinary tract infection which is causing the inflammation of the ureters and inflammation of the tubular system, and it may be possibility of the enlargement of the prostate gland, compressing on the sphincter vesicae. That's why the urine output is low. Back pressure occurs and will cause the back pressure to the kidney will cause what is called hydronephrosis, and hydronephrosis will cause the vicious cycle to the renal type of the acute renal failure or chronic renal failure, whatever it is, depending upon the time duration. The post-renal acute renal failure suspects obstruction in urea. Etiology may be the age-dependent, young congenital abnormalities of the kidneys are there. You know that there's possibility of the very high, big cysts are there in the kidney, and they are impending on the tubular system. Older male prostatic enlargement, BPH, carcinoma of the prostate, and most of them associated with lesions in the bladder or prostate or urethra. Structure of the urethra again will cause the obstruction. Now, coming about the totally whole is concerning. The primary acute renal failure, 12%, obstruction in this case is 6%, other 5%, acute exacerbation causing the failure is 18%, and ATN, that is called acute tubular necrosis, is 60% in these cases. Renal aneurysm, that is why. Back pressure post-renal will cause the renal. Now, the vascular diseases will cause the acute renal failure of vasculitis, SLE, lupus nephritis, that is, polyarteritis nodosa, Wagner's gematosis, scleroderma, thromboembolic disease, and malignant hypertension, which will cause the increase in the diastolic blood pressure. It will cause papilledema with it. And there are dysfunction of the renal parenchyma, the vascular disease. The other diseases which can cause it is the glomerular diseases, the primary glomerulopathy or secondary glomerulopathies. Acute glomerulonephritis, post-infectious or precentric type ANCA-positive diseases, that is Goodpassage syndrome, and then the anti-GBM antibodies. Now here you will find in glomerulonephritis RBC casts. These are the casts you see just like this. See this cast. And then you come to acute interstitial nephritis, drug-induced analgesic nephropathy. Interstitial nephritis. Penicillin, sulfonamide, cephalosporin, rifampicin. Second time you are using rifampicin. It will sensitize on the first occasion. Now you are doing rifamycins on the second time, and the kidney will be definitely go for the acute interstitial nephritis. Quinolones in a prolonged period of time, we are using the NSAIDs, like ibuprofen or phenobrofen or diclofenac is a very important drug. Allopurinol for the long use. That's why I am not using this drug in cases of the gout and for a prolonged period of time. Phenytoin, the anticonvulsant, thiazides for a prolonged period of time. We will call hyperuricemia, and we will call the acute interstitial nephritis. We are using for a very prolonged period of time. Again, the furosemide, the loop diuretics for a very prolonged period of time. Cimetidine, the H2 receptor, they also prone to develop the analgesic nephropathy. But there are other list of drugs are there. To acute interstitial nephritis, you will find the fever, there will be rash, there will be eosinophilia, and or you will find the eosinophilia in the urine. There will be eosinophiluria associated or cast of the eosinophil or the pyuria, sterile type of the pyuria. There is no bacterial growth in the culture and sensitivity with WBC casts, not WBC but WBC casts. If this is this condition, there was a history of drug intake for a prolonged period of time, this can happen. Even paracetamol can do this. You use more than 2 kilograms in 1 year, total dose. It can cause the acute interstitial nephritis or analgesic nephropathy. Now here you find the WBC causes, or you will find eosinophils or eosinophil casts. What terminology they are using is in the renal type is acute tubular necrosis ATN. With interrelated terminology, it means ischemic injury in a very due time, toxic injury, endogenous toxin, hemoglobinuria, myoglobinuria, rhabdomyolysis, endotoxemia, and any type of endotoxemia. Or exogenous like aminoglycosides, radiographic contrast. This is very important problem. That is why the creatinine is required before going for any of the contrast radiography. Heavy metal compounds used by Hakims, and ethylene glycol used in the industries, methanol. Those people who have alcohol addicted, they have not found, and they made the alcohol in their houses. This is produced methanol. The carbon tetrachloride, again, is the agent which you use in the industry, and cisplatin is the drug we use as a chemotherapy. And other drugs, there are long list actually of the clinical studies, high risk settings of ATN, clinical setting frequency is this. In internal medicine and intensive care and open heart surgeries, aminoglycoside, burns, rhabdomyolysis, cisplatin using as an agent specifically using in bronchogenic carcinoma as a chemotherapeutic agent In ATN sediment, you see this tubular cast now here. These type of the cast, granular cast, waxy cast possibility. Diagnostic approach to the ARF, the history should be there, the physical examination should be done, assessment of the urine volume in 24 hours, urine analysis should be done properly. Blood chemistry, I've said already about it. That is blood urea, serum creatinine, and the markers of the electrolytes, sodium, potassium, chloride, bicarbonate, and the blood indices and the urine indices. Radiological studies can be performed, ultrasonography can be performed. One is a marker which we use actually is a fractional accretion of the sodium. It is calculated by urinary sodium divided by the serum sodium. First of all, you calculate this. And then you calculate the urinary creatinine and the serum creatinine, and the ratio will be calculated. And these two ratios should be cut down. It is divided then and multiplied by the 100. This is called the fractional accretion of sodium. Now the use of it is here. In the pre-renal failure, look, the fractional accretion of sodium is less than 1, it is more than 1. Urinary sodium less than 20, in acute renal, in case of the renal ATN, more than 40. Urine osmolality is more than 500, it is less than 350. Urine to plasma creatinine ratio is more than 40, less than 20. And indices, renal failure index, means urea multiplied by sodium, urea multiplied by the phosphorus and creatinine, it is less than 1, it is more than 2. But this is very important. Now, fractional accretion of sodium, if you calculate it, you can confidently say that it is pre-renal failure or it is the renal type of the acute renal failure. Urinary sediment, benign. Usually it is in the iodine class sediments. Now here you find in the ATN of renal region the abnormal coarse granular cast, the waxy cast, the renal tubular epithelial cells. The treatment of the acute renal failure are the general measures. Admit this patient, resuscitate it for the fluid overload, for the hyperkalemia, acidosis. Manage these things, first of all. Go for the differential diagnosis. What is the cause? Underlying secondary acute renal failure, pre-renal failure or ATN, or it is the primary renal failure. Take the biopsy, obstruction, retrograde pyelography. Nowadays they are doing the CT pyelography. And then you go for the etiological treatment. Improve the cardiac output, rehydrate the patient. Acute tubular necrosis, loop diuretics, mannitol, dopamine should be given to increase the blood supply. And symptomatic treatment, maintaining homeostasis. Dialysis prevent common complication. Now these means the general measures should be done, and the specific measures are what you do is the fluid balance, acid-base balance, electrolyte balance, and the calorie balance. If you do it properly, then patient will come out. And specifically, if there is any condition, for example, reduce output, improve the cardiac output. If it is because of the acute renal left ventricular failure, manage the left ventricular failure. Then you go for the symptomatic treatment, you go for the preventive treatment, and you go for the dietary, measures. Dietary measures in this condition is lowest protein diet should be given. It should be very, very low in protein. All the carbohydrates can be given, the fatty diet can be given in these patients. Now, afterwards, if it is hyperkalemia patient, it has never occurred in the absence of renal excessive problem. Usually it is hyperkalemia, which is called pseudo-hyperkalemia, there is severe leukocytosis or thrombocytosis or prolonged application of tourniquet will cause the pseudo-hyperkalemia, should be ruled out. It should never occur in the absence of renal excretory problem. Never. Hyperkalemia is an urgency, life-saving measure should be. Role of the ECG in the making the diagnosis. Hyperacute T waves should be there, and there will be a QRS interval should be decreased here, and very low or very small P waves. Now, clinical setting in which it occurs is the acute renal failure and the chronic renal failure. You look this. And if it is 4, it is 7, and it is 9. Normally this is. It is going up the hyperacute T waves. T waves are going up and up, and there will be ST depression along with it. 9. P wave is gone. There is no P wave. Patient goes into atrial fibrillation now. Now, treatment of the hyperkalemia, first of all, the calcium gluconate is tried. 10 to 30 ml of 10% solution intravenous. Calcium gluconate will antagonize, and it will excrete out the kidney, the potassium, intravascular space from the kidneys. Secondly, you can use the insulin and glucose. It will increase the entry of the potassium into the cells. You give insulin 10 units intravenous bolus along with the glucose, 5% dextrose, or 20% dextrose in 50 ml. In 30 to 60 minutes it will work. Very, very quickly, because of the patient with atrial fibrillation, he will die at any time. You use calcium gluconate. If time allows, then you can use insulin and glucose. Still the time allows, and there are chances of the damage to the heart. You use the sodium bicarbonate because it will increase the potassium entry into the cells. It will act in 30 to 60 minutes. We use where there are chances of cardiac damage in due time. The albuterol, salbutamol, increase potassium entry into the cells. In the nebulized form, you will get 20 milligram. It will work in 60 minutes. It will also increase the potassium entry into the cells. The mechanism is the same. Or caxylate, it will excrete. It is actually the ion exchange reason. It is removal of the excess potassium from the intestine. That is, caxylate is available. But not in an acute condition, you will first of all settle this patient to 5 to 6 milligram of the potassium, then you use the caxylate. If all are failed, you will go for the hemodialysis, removal of the potassium abruptly. Dialysis, bath potassium concentration. Wherever it is, it will act in 30 to 60 minutes. Ultimately, you go for the hemodialysis where the potassium levels are higher and all the measures are failed, and the patient is still oliguric. Indication for dialysis are the uremic symptoms: appear, nausea, neurologic, severe fluid overload, signs are there, refractory electrolyte disorders. You are not managing the hyperkalemia properly. It is higher and higher, going higher and higher. You go for the dialysis, hemodialysis, severe refractory acidosis. You have given the sodium bicarbonate, but it is not functioning, and still patient is acidotic. Dialysis in acute renal failure, the renal failure causing the pericarditis or neuropathy or mental status change, or there are evidence of seizures, bleeding, toxins, ethylene glycol, methanol. Specific antidote should be used in this condition. And prophylactically, the recent studies fail to document benefit. Prophylactic measures cannot be done. Go for the intake-output charting properly. Go for the avoidance of the drugs which are nephrotoxic. Go for the balance of the fluid, balance of the electrolytes, balance of the acid-base balance, acid-bases. The patient will come out ultimately. Mortality associated is overall is 40 to 60%, post-traumatic 70 to 90%. Medical causes 15 to 40%. Surgical cause 40 to 80%. Non-oliguric patient means it is not oliguric, normal urine output 26%. Oliguric patient 50%. Usually the ATN, acute renal will cause the death. See, the underlying disorders, infections, septicemia, cardiovascular, neurologic, hemorrhage, always causes. So this is the condition in which we call the condition acute renal failure, perirenal failure, or renal failure, or post-renal failure. In the post-renal failure, lastly, if they are, because mostly they are surgical causes, which are obstructing, go for the surgery and do it, and relieve the patient from this in a due time. This is how we manage it. Always remember, you will write the management in the steps: general measures, specific measures, symptomatic measures, like this, and then dietary measures, and the preventive measures if possible, the surgical measure if needed, the dietary measures you apply for it, or local measures you apply for it. You should write it down on the piece of the paper, the management strategies, and fill it up, whether applicable or not applicable. If it's not applicable, write it down, not applicable. So this is the end of the session. I hope that if you try to understand, you can do it. It's very easy to understand. If you are not listening properly, then it is difficult. It is the concept which is given by me. I hope that you have enjoyed it, and probably you can remember it. Wama alayna illa al-balagh. Assalamu alaikum wa rahmatullahi wa barakatuh.